The first of these three rapid-fire talks about fetal abnormalities will cover twins, amniotic fluid volume, and the fetal GU tract. First, some words about the ultrasound assessment of twins. A bit of background, setting the stage when we address twins. Remember that perinatal complications, morbidity and mortality, are much higher in twin pregnancies than in singletons. Basically, every bad thing that can happen to a fetus or to a pregnant woman is much more common with twins and higher order multiples. Ultrasound is critically important in evaluating the pregnancies, and remember, we're the first opportunity to diagnose twins. The earlier the diagnosis is made, the better the outcome. Perinatal mortality is 4 to 10 times higher in twins than in singletons, and this chart on your right is to show you how quickly the rate of twins is rising in America. From 1980 to 2009, the rate of twinning has doubled, mostly because of assisted fertility. And I will say in this slide and repeatedly that the risks of outcomes of twins is very much dependent on chorionicity and amnionicity, so we have to go back briefly to embryology and review the types of twinning. Dizygotic, referred to in the sort of lay terms as fraternal twins, are fertilization of two ova, so siblings in the womb at the same time. But those of us who do ultrasound really focus on monozygotic twinning. I avoid the term identical, and you'll soon see why, which result from a single zygote that separates after fertilization. So with dizygotic twins, two fertilized eggs, necessarily two placentas. With monozygotic twinning, don't forget that the split can be early enough that it follows the path toward your left and ends up with two placentas, but it's much more common, unfortunately, for the split to occur later, resulting in a single placenta monochorionic pregnancy, either two amnions or one amnion very rarely. So a bit of a recap. All dizygotic twins necessarily are dichorionic, two placentas. Monozygotic twins, single fertilized egg, depending on the time of splitting, may be di or monochorionic. Okay? On the flip side, though, when we do the ultrasound, we don't know what happened initially. All we see is what has developed since. If we see two placentas, dichorionic, that might have arisen from a dizygotic or monozygotic pregnancy. And if we see a single placenta, we know necessarily they're monozygotic. Focusing on the chorionicity, making that part of the exam and making it part of your report is absolutely crucial. And I'll tell you, we see a lot of complicated twins at UCSF, and it's heartbreaking how often patients are either incorrectly diagnosed or not mentioned at all. They're told they're having twins and there are two sacs, and that's all that's said. And we can do better, we must do better. So I'm going to encourage you to look at these slides and try not to look at the headlines and see if you could make the diagnosis. These are a couple of examples, endovaginal views of very early dichorionic, diamniotic twins. There are two placentas with thick wedge of echogenic tissue separating. On your left, the yolk sacs, and on your right, embryos, each in their own amnion. Another example, later in pregnancy, transabdominal view, you see thick wedge of echogenic chorionic tissue separating the sacs, necessarily two placentas dichorionic. And contrast those examples with these endovaginal views of three separate pregnancies, all monochorionic, a single rim of echogenic tissue, but internally the embryos are each within their own amnion and nothing else separates them. Over time, those two amnions abut and sort of merge into an appearance of a single membrane, though it really is two layers of amnion separating them. The thick membrane that we see later from a dichorionic pregnancy, should it present later, is actually comprised of 4 layers of tissue, 2 layers of amnion, and 2 chorion, as shown here. Sometimes we don't have the opportunity to see pregnancies very early on, and we have to make the best guess or determination later in pregnancy. And you can understand now why the membrane thickness is different in dichorionic versus monochorionic. When that membrane is parallel to the sound beam, it can be quite faint and hard to see in the monochorionic chorionic pregnancy on your right, more obvious on your left. And this observation using path specimens as a correlate can help you as well. On your left, some would refer to that as the lambda sign or the twin peak sign, where chorionic tissue is growing up into the base of the membrane. That can't happen in a monochorionic pregnancy where the amnions meet at a perpendicular angle to the fetal surface of the placenta. So that image on your left is the parallel to this image on ultrasound, like I said, referred to as the twin peak sign. It's a helpful sign. I encourage you to use it and look for it. It relies on two placentas abutting and growing into the base of that membrane. It is not an absolute necessary observation. It's also a transient observation. So I must say, I think some of the mistakes I see made are people looking for the twin peak sign, and if they don't see it, concluding monochorionicity, and that's incorrect. If you see this, you can confirm dichorionicity. In that way, it's useful. What else can you do to try to determine chorionicity if you don't have access to early images? You look for two placentas, you look for a twin peak sign, and you look for fetal gender. And this is probably the most useful, medically useful reason to look for gender, because if you see two different fetal genders, you know there must have been two fertilized eggs, must be two placentas, necessarily dichorionic. And I dwell on this observation because monochorionic twins are at increased risk of complications. Ultrasound is necessary to make those diagnoses and crucial in offering interventions that can be life-saving. In particular, we think about twin-twin transfusion syndrome, but there are other complications to consider. Before we embark on a discussion of those, I just want to make this point. Monochorionic twins are growing from a single placenta. It is not the way things should be. It is not ideal. And if we could fix that, it would be great. Given that we can't reassign the number of placentas or redistribute how the placenta is shared, all we can do is recognize that if there is unequal sharing of that single placenta on which two fetuses are trying to grow, it helps us understand what we're seeing and optimally manage the pregnancy. Discordant size, weights of the monochorionic twins is not synonymous with twin-twin transfusion syndrome, and we refer to this as unequal placental sharing. It comes from understanding the placental anatomy. On your left is a monochorionic twin pair where the cord insertions are on either side of that placental pie, and the dividing line is down the middle. But on your right, this placenta is unequally shared, one twin with a central cord and one with a velamentous cord. And it's no surprise that the twin growing from a third of this placenta won't be as big. Besides the issue of how that placenta is shared, you're probably familiar with the notion that monochorionic twins have vascular connections. There's crosstalk in the placenta. Basically, every monochorionic twin pair have connections that send blood from one twin to the other. This is the anatomy of an artery-to-vein anastomosis. The blue artery is coming from the twin on your left, feeding a piece of placenta. The blood draining from that placenta is coming out toward us in the red vessel, and instead of going back to the source, going to its twin. So that's an AV anastomosis. Depending on how a placenta is shared and on how many of those connections, the direction of flow in those connections, goes a long way to explaining what we see when we do ultrasound evaluations of monochorionic twins in utero. The syndromes in particular we're going to look for and potentially diagnose and treat are twin-twin transfusion, twin embolization syndrome, and a cardiac or TRAP sequence. Starting with twin-twin transfusion syndrome, it's the most common serious complication. It's what we're most worried about once we diagnose a pair as monochorionic twins. We're on the lookout for the development of this syndrome, reported to occur in about 10 to 20% of MC twins, so a pretty common scenario. There's huge variation in the severity of this condition, and if you go back to thinking about that placenta, it goes a long way to explaining the variability of what we see. We're looking for a donor and a recipient, one sending blood to the other. The prognosis is poor for both, high risk of loss of both, and if either survives, significant long-term morbidity risk, including neurologic sequelae. The donor in this case is adherent to the anterior uterine wall. It's held there by the thin membrane in an oligohydramniotic sac. It is hypovolemic, sending blood from an artery to vein anastomosis to its recipient, who is dependent in a sea of polyhydramnios. So the necessary observations to diagnose twin-twin transfusion must be in a monochorionic twin pair, must have concomitant abnormal fluids, not just low and high, but true oligohydramnios and polyhydramnios, defined as a deepest pocket less than 2 in the donor, deepest vertical pocket greater than 8 in the recipient. That constellation of findings equals the diagnosis of twin-twin transfusion syndrome. We'll look for different sizes in bladders, as you'd expect, and different sizes in discordant weights. Those aren't necessary to make the diagnosis. It's the observation of concomitant oligo and poly in a monochorionic twin pair that yields the diagnosis of twin-twin transfusion. And this slide is meant to remind you that you might have oligo in one and normal, or poly in one and normal, and those have potential differential diagnoses, but those are not the same as twin-twin transfusion syndrome. Another example with the thin membrane nearly applied to the donor who's nearly stuck with a minimal amount of fluid to measure, and the polyhydramniotic recipient. As for measuring those pockets, we use this number to confirm the subjective assessment. The donor pocket here is less than 2, recipient deepest vertical pocket greater than 8. In going along with those variable amniotic fluid volumes, you'll see different size bladders, usually large in the recipient who's polyuric, quite small or sometimes not even visible in a donor who may not be making urine any longer. As for the estimated fetal weights in a monochorionic twin pair affected with twin-twin transfusion syndrome, this is very common, but it's not necessary. This discordance in size with the recipient typically equal to dates and the donor quite a bit smaller. I encourage you to do this calculation and report it, which is the estimated fetal weight discordance. Part of every monochorionic twin report in our lab makes mention of the discordance. It's the larger weight minus the smaller weight divided by the larger weight, in this case a whopping 43%. Worrisome abnormal discordance is over 20%, and think back to those placentas. That discordance is often because the donor has a small piece of the placental pie. The term stuck twin has been introduced in the literature a while ago, and you might use that. It refers to a fetus so oligohydramniotic, so anhydramniotic, that the membrane is holding the fetus up against the uterine wall. The membrane is no longer directly visible because there's no fluid on the internal side of it, but you can confirm its presence because fetuses don't float. So if you maneuver the mom and show that this fetus is adherent, you can confirm it's stuck, confirm there's a thin membrane, and the most common explanation for this phenomenon is the donor of a twin-twin transfusion syndrome. One more example of that condition. What to do now that we've made this diagnosis, early diagnosis of monochorionic twinning, recognized twin-twin transfusion. Some of the treatment options are listed here, but I'll tell you, if we pick up these pregnancies early enough, the preferred treatment is laser coagulation. We put a scope inside the polyhydramniotic sac of the recipient fetus, ablate those connections that I showed you, and offer the best possible outcome for both. Moving on to another less common complication of monochorionic twinning, referred to in the literature as twin embolization syndrome. It follows the in utero death of one of a monochorionic twin pair. The name is kind of unfortunate, and it's a little misguided. Historically, this was thought to be due to some bad act or even clot within the circulation that traveled from the dead twin to the surviving co-twin. But that's no longer the presumed mechanism. Rather, the surviving twin likely has an acute change in placental circulation when its co-twin dies. And in that moment, when the placenta is the placental circulation is redistributed, the surviving twin has a hypotensive bradycardic event, and the organs that take a hit: brain, kidneys, and bowel. And in particular, we're looking for brain injury in the survivor of a co-twin demise. It might take some weeks for it to be manifest on ultrasound. You can see here abnormal increased echogenicity in the periventricular white matter. In cases such as this, we often confirm that observation with fetal MR, and I'll talk more about that in my second talk this morning about fetal CNS. A few words about acardiac or parabiotic twins. This is quite rare, but I talk about it partly because it can be misdiagnosed and therefore a late pickup and altering the outcome if it's not correctly identified. If you didn't know that this condition can exist, it's not something you would imagine. It arises in a monochorionic twin pair. There have to be vascular connections. One of the terms for this is TRAP sequence, which stands for twin reversed arterial perfusion. One twin is structurally totally normal with a potential good outcome, but the co-twin, you can see a path specimen here, is distinctly abnormal and not viable, usually acephalic, with diffuse edema and hygromas. Rarely does it have upper extremities, but the lower extremities can be quite recognizable. The telltale observation is that the blood flow to the acardiac mass is reversed and being supplied by the good normal pump twin. So some grayscale suggestions. You can see this unusual looking fetus with diffuse edema and cystic hygroma, a recognizable lower extremity. It has no beating heart, but there's flow inside that tissue because of the pump twin. And therein lies the opportunity for error. We see people who've been told that they have twins, but one's dead. In follow-up, it's realized that that dead twin has grown. And it's because even though it doesn't have its own beating heart, it's being perfused by the pump co-twin. Here's another example, and I'll show you the Doppler proof of this entity. The pump twin looks fine, although it is at risk for a high output state with polyhydramnios. And this is quite characteristic morphology of the TRAP fetus, spine identifiable, but no head, no arms, no heart. The cord insertions, there must be only one placenta. The cord insertions are typically quite close. A normal fetus sends blood in the umbilical artery toward the placenta, but the TRAP fetus, you'll see, has blood flow, arterial flow going away from the placenta, and this is the telltale necessary image. An image at the abdominal wall of the acardiac fetus showing blue signal, pulsatile arterial flow going into the fetus. That's reversed. Thus the term TRAP, reversed arterial flow. And you can see at the cord insertion sites into the placenta, normal pump twin toward the placenta, acardiac twin has blood flow away. There's only one potentially viable fetus in this pregnancy, and if we don't intervene, the risk of loss of that pump twin is 50%. The preferred in utero treatment at this time is radiofrequency ablation under ultrasound guidance, obliterating flow to that acardiac mass. Moving from twins to amniotic fluid volume, there's some overlap, of course, because twins have abnormal fluid sometimes. After 20 weeks, remember that the fetus contributes to the homeostasis of amniotic fluid through renal function and swallowing, and the fetus needs amniotic fluid for normal development. Abnormal fluid in either direction can be the first indicator of the problem, and it can be a rather immediate subjective assessment. I encourage you and the sonographers with whom you work to trust your eyes. If something doesn't look right, forget the numbers, we'll come to those, but look at the image, and this doesn't look right, trust your instincts and pursue that. So subjective assessment is quite good. Then you can use the numeric values to corroborate your subjective assessment and also to convey to people who are reading your reports. So it's not like I make the diagnosis on the number, I use the number for communication. The numbers you can use are amniotic fluid index, which is the sum of the deepest pocket in all four quadrants. Remembering that sometimes the pocket is biggest near the middle of the uterus rather than to the edge. It sometimes can be easier and more reproducible rather than an AFI to report a single deepest pocket, and that a normal measurement is between 2 and 8 centimeters. At the extremes, it comes as no surprise, the more extreme the poly or oligohydramnios, the worse the outcome. So here's an example. Even without numbers, we can see that this fetal abdomen does not fill the uterine cavity front to back. This we know is polyhydramnios. We can use the measurement to communicate the degree. This chart is to show you what I mentioned about the extremes being associated with worse outcomes, and as the pocket diameter goes up to the right, so does the risk of fetal anomalies. A differential for polyhydramnios, once it's been made, that's going to guide your next steps, inform your targeted survey. Like any differential, it's best to sort of prioritize the top 3 on this list, and it's a long list, are highlighted here: CNS anomalies, GI tract, and twins. I don't want to steal Ruth's thunder. She's going to talk about GI tract abnormalities in the next session, but a next place to go once polyhydramnios is seen is the fetal stomach, a normal on your left, non-visible on your right due to esophageal atresia, abnormally positioned on your left due to a hernia, and abnormally dilated with duodenal atresia on your right. She'll come back to those diagnoses and spend more time. I just want to emphasize how once poly is seen, the stomach size and position is a really helpful next area of interest. The CNS anomalies we'll come back to as well. Moving our way down the list of this differential, prompted by the observation of polyhydramnios, are some conditions where the fetus is in a high output state. For example, a mass like this, predominantly solid in this case, with lots of flow shown with power Doppler arising from the caudal end of this fetus. This is a sacrococcygeal teratoma associated with polyhydramnios because it's such a vascular mass with high cardiac output. Another mass that can give rise to polyhydramnios is seen here along the fetal surface of the placenta. Lots of flow, typically located near the cord insertion site, a chorioangioma. And when you see polyhydramnios, it has happened. People don't realize that there is a twin, and you have to do some searching to find it with profound twin-twin transfusion syndrome. So coming back to the reminder, don't forget twins. On the other end of the spectrum, when there is not enough fluid, defined as an AFI less than 5 or a deepest pocket less than 2, again, subjective assessment would go a long way. This is bad for outcome to not have enough fluid in the sac for fetal development, and typically an indicator of a fetal abnormality. The differential diagnosis, once oligohydramnios is recognized, is listed here. Premature rupture of membranes clearly is common, but those of us who are doing the ultrasound can't rely on that. We can encourage it be considered, as can dysmaturity and post-dates. We are looking for growth, and we are particularly looking at fetal malformations. The GU tract would be the next area of focus, and I suggest the target next image be the fetal bladder. The reason being the bladder could be way too big or way too small, giving you the next step in the differential for the oligo. In this case, this bladder is clearly abnormally big, so we are dealing with a form of bladder outlet obstruction. Here's the differential for bladder outlet obstruction resulting in oligohydramnios, and the top of the list appropriately is posterior urethral valves. What we go looking for, in addition to the dilated bladder, is the morphology of the bladder. And even though it's an oligohydramniotic pregnancy and a hard-to-scan pregnancy, if we know we're looking for bladder outlet obstruction due to valves, it can target the views such that we see the telltale keyhole configuration. And if there is enough fluid to just barely see the gender, we expect it to be male and can confirm that. That is not always possible. In addition to the dilated bladder with the characteristic dilated posterior urethra, we often see associated hydroureteronephrosis as shown here. This constellation of findings with oligohydramnios can result in lethal pulmonary hypoplasia. Going back to the bladder, on your left is a normal-sized bladder, but oligohydramnios may be seen in the setting of a non-visualized, apparently absent bladder, usually present but non-filled. This indicates a bilateral renal abnormality. One good kidney would give enough urine to fill the bladder, but if there's no fluid in the bladder, it's bilateral, and the differential is shown here. We'd think about multicystic dysplastic kidney, bilateral absent kidneys, or autosomal recessive polycystic kidneys, and we'll go through those conditions. So we are in the setting of oligohydramnios with an absent or non-visualized bladder. We've looked at the bladder, now we're looking at the renal fossa. And these images, which are not the prettiest, but they show what we need to see. We do not see hydronephrotic kidneys. In fact, we do not see kidneys at all, but we are seeing a fetal adrenal gland. So we are clearly looking with adequate technique in the right location. This observation, termed the lying down adrenal sign, is an indication that a kidney is not present in the renal fossa anyway. And in this instance, neither kidney could be found in the renal fossa or anywhere. The bladder remained empty. It's a case of bilateral fetal renal agenesis, a lethal condition. Usually it's an isolated abnormality, but it can be part of a genetic syndrome, and the reason that's important is it's associated with a 25% recurrence risk. And it can also be familial, and I'll tell you that in 9% of cases, a first-degree relative has unilateral renal agenesis, and it has happened that we've diagnosed bilateral renal agenesis in a fetus, prompting us to look at relatives, including the mom, and finding that she is missing a kidney, and that was never before known. So it's worth additional workup for purposes of counseling risk for future pregnancies. Okay, back to oligohydramnios, absent or non-visualized bladder. We've looked at the bladder. We're now looking in the renal fossa. Two different conditions here that can give rise to this scenario. On your left are bilateral large echogenic kidneys without resolvable cysts, an example of autosomal recessive polycystic kidney disease, the characteristic appearance. And on your right, kidneys are present, but there are cysts. This is not hydronephrosis. These cysts are scattered, variable in size, and this is a case of bilateral MCDK, multicystic dysplastic kidney. The final words are about fetal GU malformations, and you've seen some of these examples. We'll talk about hydronephrosis and cystic disease. As for hydronephrosis, it's worth remembering that, like in postnatal life, the level of obstruction can be at the UPJ, at the UVJ, or bladder outlet. The associated sonographic findings and the differential would be informed by that observation. So starting with dilatation of the renal pelvis, but of nothing else. First, the definition. I think it's helpful to have some numbers upon which to rely when you're diagnosing an abnormally dilated fetal renal pelvis. A little bit of fluid in the renal pelvis is normal, is physiologic, is accepted, and is not worth overcalling. So my suggestion to you is to make note of renal pelvises that measure more than 4 millimeters before 20 weeks, more than 7 millimeters before 30 weeks, and more than 10 millimeters anytime in pregnancy. And those numbers come from literature that indicate that is associated with a significant enough risk of true pathology worthy of postnatal evaluation. So here's a case clearly abnormal. The pelvis is dilated, as are the calyces, but there's no dilated ureter or bladder, and this is an example of a UPJ obstruction. In this case, the bilateral renal pelvises are dilated, and I just want to remind you that the postnatal workup is prompted by these observations. In this case, this was proved to be reflux, so not all dilatation is obstruction. If, in addition to a dilated intrarenal collecting system, hydroureter is seen, we think about a UVJ obstruction or reflux. And remember that a ureterocele can give rise to this appearance. Ureteroceles deserve kind of special attention. You need to image the fetal bladder at the right time so that there's fluid in the lumen surrounding the fluid-filled balloon of a ureterocele. If a ureterocele is seen, remember that's often associated with a duplicated renal collecting system. This is postnatal evaluation of a fetus who had been seen in utero. You'll see this entity again later in the week when the pediatric section presents the upper pole dilated and the associated ureterocele in a case of duplicated renal collecting system. And we talked a bit already about bladder outlet obstruction giving rise to hydroureteronephrosis and dilated bladder with the characteristic keyhole configuration from valves. Hydroureteronephrosis can, if untreated, injure the kidney in an irreversible way, resulting in cysts. So this case is sort of a segue to a discussion about fetal renal cysts and cystic dysplasia. When it comes to cystic disease of the kidney, important observations are unilateral or bilateral, and the size and distribution of the cysts and size of the kidneys. I'll remind you of Potter's classification regarding cystic disease of fetal kidneys, and in particular, remember that types 1 and 3 are the heritable causes of cystic disease, autosomal recessive, I showed you an example earlier, and the rarer form to diagnose in infants, the autosomal dominant. Here's an autosomal recessive one more time. Markedly big kidneys, typically echogenic, typically without resolvable cysts. And in terms of what is considered abnormal, there are nomograms you can refer to. Ballpark rule, a normal fetal kidney length is about 1 millimeter per week. The other two types in the Potter classification scheme, types 2 and 4, refer to cystic dysplasia, abnormal development of the renal onlonga, MCDK is type 2, and the acquired cystic dysplasia, for example, resulting from valves, is referred to as type 4. Here they are side by side. From whatever cause this might be, remember that cysts in the kidneys, in the fetal kidneys, are never normal and are a sign of irreversible renal damage. If bilateral, then preclude normal development, normal urine production, and oligohydramnios.